This episode is brought to you by Nordstrom. Summer's almost out and fall's calling. Luckily, Nordstrom has everything you need for the season ahead, all under $100. Discover new arrivals from your favorite brands like Mango, Princess Polly, Wave, Free People, BDG, and more. Whether you're planning a last-minute getaway, heading back to class, or refreshing your office looks, you'll find the latest trends and beauty must-haves without breaking your budget. It's easy, too, with free shipping, free returns, and in-store order pickup. Shop today, in stores, and at Nordstrom.com.
This episode is brought to you by Espolón Tequila. Slow, sticky, snoozy. They call these the dog days of summer. But Espolón? They don't do boring. Welcome to the Marg Days. Espolón Tequila. 100% blue Weber agave, born to shake up your summer. Just add lime, agave, and a little attitude. Visit espolontequila.com. Espolón Tequila, 40% alcohol, volume 80 proof. Copyright 2025 Campari America, New York, New York. Drink responsibly.
This is Dr. Sonya del Tredici from the Addiction Medicine Journal Club. We have a special episode for you today. We did a workshop-like thing with two colleagues on how to keep up with the addiction medicine literature. If you've ever felt overwhelmed, like your knowledge is falling behind, or you're just not sure what to do now that you're out of training and no one's breathing down your neck and making you study, this episode is for you. If you want to hear more about current addiction medicine research and get some free CME, take a look at our other episodes.
All right. Well, we have a meeting of the minds. It's afternoon my time and it's evening for all of you. But we are going to collectively geek out on how to keep up with the medical literature in addiction medicine. Tom, why don't you start by introducing yourself and tell us what you do?
Sure. So my name is Tom Bannard. I am the Assistant Director for Substance Use and Recovery Support at Virginia Commonwealth University. So I work with our collegiate recovery program. We work with students who are in recovery from addiction, and also help students get into recovery. And so we do that through a number of different things, including trips, that sort of thing, but also kind of some more formalized structured seminars. And then I kind of have part of our mission is to make sure that everybody that studies a health-related science at VCU, so whether that's professional school or otherwise, get some exposure to people who are in recovery from addiction and kind of interacts with folks that have that lived experience of recovery, so that when they go out and work in medical spaces, they can hold that hope for their patients, which I think is a really important part of our work. And I'm a big fan of both y'all's podcasts, so I'm excited to be here.
Yes. So I'm Casey Grover from the Addiction Medicine Made Easy podcast. I almost just forgot the name of my podcast. Good heavens, it's been one of those days. Sonya and John, you want to go next?
Sure, I'll go. And I just have to say that Tom threw an awesome conference that we went to recently. So anyone else who wants to go to Rams in Recovery at VCU Health next year, highly recommend. I'm Sonya del Tredici, one of the hosts of the Addiction Medicine Journal Club podcast, and I love talking about evidence-based medicine. I teach evidence-based medicine to our residents, and I, of course, do it for our podcast. And I'm interested in how sort of the practicing doc stays up to date and stays current. So that's why I wanted to do this episode.
Yeah, my name's Dr. John Keenan. So I'm Sonya's co-host for Addiction Medicine Journal Club. And I'm a family doc. I do some medical education as well, though I'm not faculty like Sonya is. So she's the full-time academician here amongst us. But I do get to teach our residents. I also work inpatient, outpatient, have a admin role, do some other like subgroups. So I also take care of HIV patients. And so certainly high volume outpatient practitioner, but enjoy these conversations very much so.
So I'm going to tell you something funny, Sonya. So when I was a pre-med, I remember they would assign us papers to read. And I thought to myself, when I am a doctor, I am never going to read any papers. So why don't you start by telling me what I didn't know as a pre-med and why evidence-based medicine matters?
Right. Well, and I think just to acknowledge that evidence-based medicine is more than reading those like super dense papers. That is one of the foundations, but you can be a fully up-to-date doc without ever having to read those original foundational papers. And the reason we have to do this is one of our professional obligations. I mean, as a medical professional, you are expected to know current treatment. Like our patients would be horrified if they realize that maybe we're offering them a medicine and there's a better treatment that we just don't know about because we didn't bother to learn. It's an expectation that you are up to date. I remember for myself, I was kind of blown away. I had like a second year rotation with a family doc. You're like learning to do physical exam. You have a little internship thing with a practicing doc. And he told me he got up at 5 o'clock every morning to read. Every day from 5 to 6 he read. And this is it wasn't pre-internet, but pre like online resources. So he was, had journals and books and he read them every single day. And I was like, oh, is that what it takes to be a doctor, be a family doctor? That was very meaningful to me. And I've always thought of that. And in addiction medicine, it's even more important because our field is really changing a lot. The drug supply changes, the political climate changes. It's just constantly evolving, more so than some other fields, I think. And also we're a small field, so the resources aren't as mature and well developed. So I think it's hard to stay up to date hard to stay up to date in addiction medicine. But yeah, I think it's just super important for us.
So, Tom, you put together an educational conference on addiction. What did you highlight? How did you make it interesting? How did you make it good?
So this is a conference. It's called Research to Recovery, and we've been doing it for about 8 years. And so I got into the field really from my lived experience. I got into recovery when I was 22, so about 18 years ago, and I didn't have any plans to kind of before that. While I was in active use, I didn't have any plans to work in this area, and then got real passionate about it after kind of being helped by some folks that kind of knew what they were doing a little bit. And so when I started my career, and this is kind of, I come to this from a pretty different perspective as y'all. um, I was kind of just thrown in. I was working in a homeless shelter that had recovery support, and and we were just kind of thrown in, and you know, figure it out as you go along. And that had a lot of kind of consequences for the folks that we served in terms of, you know, we probably didn't serve them very well or as well as we could have. And I that weighed on me as I learned more. And so when I moved over to the university about a decade ago, um, it one of the things that was apparent to me was I had access to all this knowledge just right next door. I could go to a lunch lecture with these brilliant folks and learn more than I had access to when I was working in homeless services. And so it became really important for me to kind of give the education that was so easily available to me now that I was in a university setting back to folks that were providers, that were especially peer recovery specialists, that sort of thing. So that's been cool. It's been cool, and part of that is we've produced real high quality recordings. And so it was a little bit pre or beginning of the podcast era. So it was that kind of idea of let's record these brilliant people like Sonya and John, and make sure that folks have access to them.
Yeah, I love that. And I love the fact that you're doing work with peer support. Peer support is a huge part of my practice. So, John, I'm going to pick on you next. You mentioned that you're a very high volume practitioner. So, one of the wise attendings I worked with as a medical student talked about having to realize that just because you've seen it many times in clinic doesn't mean it's right. And his saying was the plural of anecdote is not data. So how do you reconcile all the things that you learn from your patients versus the medical literature and synthesize that into making the right decisions for your patients?
Yeah, I think I'm sure like many people here, uh, we read a lot, but I'll tell you, like practicing medicine with a like living, breathing person, it's humbling, right? I feel like you try to kind of you read the literature as kind of a starting point, and then there's always an X factor that maybe that person doesn't quite represent the sample of that study or what you kind of read about. So I think it's hard in that regard because evidence based literature or evidence based medicine is really kind of like evidence informed, right? Because we always have to kind of tailor to the unique needs of each individual person. Um, but like as a family doctor, we're kind of like the pluripotent stem cell of the medical system, right? We kind of move into whatever domain is needed. And we saw that with COVID, kind of we were redeployed to COVID for inpatient, even though many of us didn't do that. And actually, like when I started in York, Pennsylvania, that's kind of how I got into this. It was just a need in the community. We had 3 times more people were dying of overdose in our community the year I started than breast cancer. So, and there's only 1 or 2 people operating that domain. And so a lot of this has kind of been like forced knowledge acquisition on the fly. I've kind of reached out to some of like people like Sonya that were doing it for a little bit longer. She was an early mentor of mine. I had another mentor that is no longer like in good standing in the community, but he taught me along the way. And so that's kind of the start. But then from there, you have to come up with an individual plan of like how you kind of like have a staying power. I like to say, like, you're still up to date. You still know what you're talking about. You're like on the edge of what is coming out. And it's hard. The broader your scope of practice, the harder that is, right? ER is probably very difficult as well because you touch every domain and how much the treatments change from year to year. It's appalling how quickly it moves, right?
Well, and I really just want to, emphasize something you said, John, which is that, you learn about the things that are in front of you and the things that are put right in your lap. But if you only do that, you actually fall behind. Like, I think there are a lot of us who really just learn about what we see, and our residents are always trying to do that. They're saying, I'm just going to read about my patients. But like, if you do that, you end up with unrecognized knowledge gaps. So you have to read about your patients, but you also have to know that there's more knowledge out there because otherwise you're not able to cope when an unfamiliar situation presents itself. Like there might be someone having some horrible, horrible to treat withdrawal syndrome, and you don't know that like tianeptine is now a drug of abuse. And I didn't know that, you know, and you wouldn't even know to know it. Like, you don't even know what it is. And so if you don't do something that kind of takes you beyond that point of care learning, I think it also, I just think that's a requirement as well as just knowing about the problems that are, that are dropped in your lap.
Yeah, it's easy to hit the first 90%, right? It's like a diminishing returns. It's many, many more hours of studying and knowledge acquisition to get the last 1 or 2% of the interesting case, right? I think most of us could treat like an asthma exacerbation or a COPD, but then when the person comes in your office with DRESS syndrome, if you never saw that before, we're studying for it, you don't know what you don't know. So you have to have some plan. You're right to develop a familiarity with things you're not familiar with or you haven't seen.
Right.
The first day of medical school at UCLA, the dean walked into the room and drew a circle about the size of a tennis ball. And he said, "This is what you know you know." And then he circled around it about the size of a grapefruit. And he said, "This is what you know you don't know." And then he circled the entire rest of the whiteboard and said, "This is what you don't know you don't know." I will never forget that. So, Sonya, you brought this up. How do you work on maximizing your ability to learn what you didn't know you didn't know?
Well, right. And that's the whole point of this discussion. And so I guess the first thing I want to say when we're talking about this is I'm a big believer in process and consistency. So we'll talk a little bit about the process as a group, but personally for me right now, I'm glad we're having this discussion because I need a little bit of improvement too. I listen to podcasts because I have a lot of commuting time. So I fill that with learning. And I struggle to just sit down and study. And so I need like a deadline or a project. So I often, with areas that I need improvement on, I force myself into a project that then I have to learn about. So for example, I signed up to care for a bunch of transgender patients. And that is forcing me to, expand my knowledge of transgender healthcare. Or I'm about to pick what modules I want to do with our outpatient residents. We sort of divide up all the modules. So I'm going to pick modules that are areas I'm weak in, and that will force me to learn about them. So I know I'm a project person who needs like an external deadline. And then I personally love email alerts. I sign up for like high quality email alerts, and then I get the emails and I try to keep up with them. There are a lot of them, but at least I feel like I see the highlights. If nothing else, I've seen the headline. Tianeptine will be on the headline of like the ASAM, weekly newsletter. So that's kind of what I'm doing now.
You said,
but I
some
need
goals for
more.
improvement. Yeah.
I sure do. I mean, I just think I need more general internal medicine knowledge. I need to be more up to date on my general primary care practice. I'm always afraid I'm going to miss something. The residents help keep me up to date, but again, it's like point of care. If they tell me stuff that's right in front of us, but like I don't know, just a recent example. This happened to me last year, 2 years ago, I think. I didn't know that the standards of care had changed for diverticulitis. Like, you're actually not supposed to give empiric antibiotics anymore in the outpatient for diverticulitis. I didn't know that. That had totally changed, and the resident had to tell me it while I was telling her she should be prescribing, like, metronidazole and ciprofloxacin, so that's embarrassing, and, so I need more general internal medicine knowledge, that's what I think I need. So hopefully we can talk about what I will do as we go through this process.
Yeah, Tom, for us as doctors, most of us who have not lived with addiction, it's kind of hard to actually understand what addiction is like and why it happens. Can you talk about incorporating lived experience when you do education? Because that is so helpful. We actually did some presentations in my hospital where we had people in recovery come to speak to healthcare providers because of the value of lived experience. So I'd love your thoughts.
Yeah, absolutely. So like I said, I've been in recovery for 18 years, which, is an N of one. I have to like understand that like my experience is not everybody else's experience. But also that hope matters, right? And it's I think, for you as an emergency medicine doctor, you are almost entirely seeing, the patients that you see with addiction, you're seeing them at their absolute worst, right? And you know, they're not coming back generally to thank you, right, for treating them, because it was, one of the worst days of their life when they saw you, we can be difficult, right? Addiction is a really, does things to us that we pass on to other people, and I think one of the pieces for me with working with medical professionals is for them to kind of understand that there's hope for that person, right? Like that there's that a lot of us are here because you were there in that moment. And if you don't get to see the hope on the other side, if you don't get to see people that are in recovery, which is made worse because there's so much stigma within healthcare that, many people in my life don't disclose to their physicians that they're in recovery. So you don't even, you don't see us on the other side, even when we do really well, a lot of times because we're afraid of that. So I think that just kind of connecting to shared humanity is a really important piece of the kind of larger picture, without claiming that one of our experiences is all of our experiences, because it looks really, really different, based on life circumstances, socioeconomic, substance abuse, etc. So that's really when we kind of are in classrooms, we're trying to kind of expand people's view of what addiction is and also what recovery can look like for folks.
John, what's your approach to staying up to date with medical literature and addiction?
Yeah, so I think the biggest things I think I have my three primary journals I read every month. So I set aside like 2 hours once a month. So it's like the addiction medicine journal from ASAM, family practice, and then also HIV digest as well. That one has a lot of overlap because that kind of group tends to be overly representative for patients with substance use. But I'm a big fan of what Sonya said too. I love my like journal stream. So like Journal Watch from JAMA, evidence alerts. I get these kind of updated briefs in my mailbox on a weekly basis, and it picks like overviews of like the biggest 20 articles in that area. And then I can click on them and read in depth further. So it's a way of like kind of scanning the literature and then kind of getting in depth more so with what I want. Um, and then the biggest thing too is it's hard when you start to practice. If you like live in an island, you kind of like drift away from norm. And I feel like I work with the residents every couple of weeks. I'm teaching them, and they come out to my office. I have medical students, and it's sort of like dad strength at basketball. I feel like when the residents, like the young person that's hungry, is there, and they like want to like push you about learning about something, it pushes you. So I really like having them there. It's probably. I like the fact I have a lot of different hats, but working with them has really it's forced me to stay up to date because I have to maintain my competency to teach them, or else I'm not a very good teacher. And then they ask really good questions sometimes. I've never thought about it that way. And with addiction medicine specifically, I will say that like medical students like love coming out to my office on the day I do it. They are so eager to enter this space now. And it's interesting. Some of the older attendings, not so much, but the younger group, the residents, the new medical students, they like love this and they think it's amazing. And I actually we take the ER residents rotating on toxicology. They come out for a day at the clinic, and they really enjoy the experience because most of the time, as Tom pointed out, that they're interacting with this group, they're like overdosed, they're kind of not in their right state of mind. So like seeing them like recover and do well, like this person's been with me for 3 years, they got their kid back, they're in school. It's a really positive experience to kind of like show the other side of that lens, which they probably don't get in their kind of primary care area as ED residents,
That is 100% true. We actually would often message the ER doc that had taken care of a patient to let them know that they were doing well, just to give them the positive follow-up.
Yeah.
So you mentioned teaching, and I'll share a little bit about what I do. So the whole reason I started my podcast, Addiction Medicine Made Easy, is when I was a resident, when there was a difficult topic, I wanted that topic to be assigned to me as a resident. Like the patient with generalized weakness in the emergency department. It's so broad. I actually lectured on that my senior year of residency because I wanted to be able to understand the most difficult topics. I felt like if I could teach them, I had a really good understanding of them. So that's where this podcast came from. I didn't want to be a clueless physician, so I was asking clinical questions. And so researching episodes is really helpful for me. And then I'm the medical director for a local drug and alcohol treatment program, and I'm required as the medical director to give one educational lecture a month. And the one I picked for this coming month is on ketamine addiction. And I know a little bit about it. Thank you, Elon Musk, for making it popular again as a topic. So yeah, I'm going to put together a lecture for that. And I pulled some papers and I'm going to review them and I'm going to do an evidence-based review of the topic. And then I mentioned that my lovely bride, the very intelligent, charming, and beautiful Dr. Reb Close, who's sitting behind me, she works with the California Bridge, which is a program that's designed to help clinicians innovate around addiction care. And so she's one of their regional directors. And so she will be asked to give a lecture and same kind of thing. She'll be like, hey, what are you hearing about tianeptine? And then locally, we have a lot of collaborative efforts. So I'm in Central California on the coast, and there's about 4 counties that we work together. And we'll actually have quarterly meetings of like, what drugs are you seeing? What are you treating? What are your new protocols? And each county gives updates. So it's not really going to the medical literature, but it's more to your point, Sonya. What is it that we don't know? And we regionally will collaborate and talk about what drugs are people seeing? What new protocols do we have? What's the easiest way to get people on, a direct to inject protocol? I will share that I'm not great about reading like any journal regularly, but it's more organic. And because we work collaboratively, I feel like I'm able to not miss topics as much. But yeah, I probably need to find a good journal that I read regularly.
Well, and the word regularly, so here's one thing I do believe strongly, and you guys, just so everyone listening knows, they made fun of my organizational email prior to setting this up, but you got to be sort of structured. I'm a big believer in process, and I really think and consistency. I feel like if you have a consistent process and you can do it, it's realistic, and you can do it 80% of the time, 75% of the time, but you stick with it, you will get to your goal. Whereas if either your goals are too broad or too unfocused or too ambitious, and then you don't have any kind of way to stick with it, then you won't get very far. I think I used to be more of a perfectionist, and then I would get bogged down. I'm like, I'm going to read, 10 pages a day. And then I would skip the 10 pages. I'm like, okay, tomorrow I'll read 20 pages. And then I wouldn't do that either. I'm like, okay, I'm going to read 30 pages so I can stay on schedule. That's like med school, so it just didn't, it didn't work. You get behind, you get bogged down, and then you sort of, everything implodes. So having a consistent process and designing a plan that is realistic enough for you, but actually does push you a little bit and you can stick with, I think is the way to do this. So do you guys want to start hearing about my sort of framework for figuring out how to stay with the literature?
I'm going to try to be funny here. Do we get a choice?
Only if
No.
it's as organized as the pre-discussion email we got.
Would you like to give us a really organized overview of how you're approaching evidence-based medicine and addiction? That sounds like a great topic.
Everyone listening, part 1A, you're lucky you can't see the PowerPoint. No, there's no PowerPoint yet. But no, but the first thing I think actually is most important, and I really want to hear what you guys have to say, is motivation, is why. Why are you doing this? What's your unique personal goal? Because I think if you know your motivation, it's a lot easier to figure out a plan that will work for you. And I think like being a good doctor is not specific enough. Keeping current, not specific enough. not embarrassing myself in front of the residents. It's getting a little closer. But, some examples of sort of good motivation would be I want to give good lectures. Like you said, Casey, I want to give good lectures that are true to colleagues. I need to pass the boards. That might be a good motivation. Or I want to add a new skill to my clinical practice. Like, John, when you did your HIV training, you're adding a new skill. Or I need to work with med students and develop a new curriculum. So motivation, I think, is really important. So what do you guys think about motivation for staying up to literature? Why would you bother? Why not just do what comes, see what you see, and if you don't know something, you look it up and up to date as you go along.
John, you want to go first?
Yeah, I really like doing new things. So like new things and like pushing the scope of my practice, especially like I'm not kind of like niched into a specialty. So I kind of like to take it as far as I can go. And I've really kind of been lucky in life to date. I've really only kind of operated with like two goals in mind since I've become an attending. It's like do things that interest me and always try to do the right thing. And actually everything else is kind of followed behind nicely. So the number one thing I just kind of do is I just want to learn more about these different topics. They interest me. And it's easy to kind of put time into something you like to do and that you're interested in.
Tom?
Yeah, so I guess my is a little different because I'm not trying to treat all these different things. I'm just interested in addiction and recovery, and that's like been very clear to me for a really long time that was kind of going to be the thing that I was dedicating my whole life and career to. And I guess the bottom line for me is like the stakes are too high and we're not good enough. And, I've just lost so many people that I've worked with, so many friends, in recovery spaces over the last, I don't know, 17 years that I've been working in this space. That's a real motivator. And actually, the thing that always comes up for me with this is early in my career, I was working at a kind of a long-term recovery space. And I kind of switched roles and started to just work on our emergency shelter side as a large organization. So I was running a 120 bed homeless shelter, and I didn't really know anything about homeless services, especially as compared to, recovery and addiction. And I just had a couple of situations with clients where we were, basically our policy was to, if folks came in intoxicated, that we would, kind of ask them to sometimes we'd just be like, okay, just chill out. But, if this happens again, you're going to either have to go to treatment or, you can't stay in the shelter anymore. And I mean, it wasn't like, there was not enough shelter beds in the first place, but working with kind of vulnerable women who had terrible addiction that couldn't not drink, right? Not use before coming in, kicking them out of shelter was the worst thing, right? But I didn't know that because I didn't have any formal training in the work that I was doing and I didn't know the research. And so I just had this really kind of upfront experience with kind of seeing one of the women that we, asked to leave the shelter for years afterwards, living on the street. And while that was happening, I was learning what we should have been doing, and I was making the changes to our programs that we should have been doing. But I just don't want to be that, right? Like, and so there's real consequences to the folks that we serve when we don't have the knowledge that we need. And so just want to be better,
Hmm. How about you, Casey? What's your motivation?
I'm gonna try to be funny again. It's usually that my wife has some lecture that's due tomorrow and she needs me to research it for her. And I want to just be able to like answer the question. I'll have to take 20 minutes looking it up for her. Okay, all kidding aside. I think it is that the more I learn, the more I can help. And particularly, I'm doing a lot of education personally around mental health. Kind of my niche is becoming the intersection between PTSD and addiction. And so I am a little bit like John. I'll find something that I'm interested in and just dig into it more and dig into it more and get more expertise in it. And then that translates into my work being easier in clinic.
Hmm. All right. So now that we have our motivation, the next thing I want you guys to think about is sort of the what and the when. And this is where the kind of realistic thing comes out. Like you might aspirationally be like, I'm going to read this giant textbook, or, Casey, you're going to change and you're going to read journals, lots of journals, you know. But no, it's realistically how much time do you have? when is that time and what kinds of things do you like to learn from and that actually work for you? So, you know, probably zero time is not a good answer. If you have zero time for learning, you need to adjust your work such that you have some dedicated time if you're in a field that changes. But, some people say their whole education is one full week a year to a conference. That's what they do. And that's a lot. That's a full week's worth of time. That's pretty good. Or 15 minutes every day. Or for me, it's at least an hour a day of commuting time is an educational podcast. Because I commute 2 hours a day. So realistically, what time will you spend on it and when? And then what type of learning do you like? And it's easier to stick with things you like. So videos, podcasts, emails, books, journals, conferences, other people, do you need to chat in person? Can you just read all by yourself? And just to sort of choose a gateway, because like dealing with medical knowledge, there's an entire industry that helps people deal with medical knowledge, abstracting services, board prep resources, conferences, YouTube channels, and a lot of them are pretty expensive. Like there's a whole industry out there. So just sort of to choose a gateway, but don't try to do it all. I again, like med school, which is of course our like fire hose of learning. I remember thinking like maybe if I buy like a different textbook or another textbook, I'll like know more. And eventually I was like, you know what? Just choose one textbook and stick with it. It probably tells you what you need to know in that textbook. Just don't get a second one. Just read that one. So what time and what's your resources that you like is the next question.
I'll take this one first. So I have not found it yet in addiction medicine. In emergency medicine, there is an Australian ER doc named Mel Herbert who figured out that if you made education funny, it stuck better. And so when I was practicing emergency medicine, I had a subscription to this service called EMWrap, Emergency Medicine Reviews and Perspectives. And it was humor, soundtrack, funny songs. The host would banter. It was beautifully done. And I was about 2.5 hours per month of topics. They rotated. There was a very wide breadth because emergency medicine, you have to know a little bit of everything. And then they additionally had a second program called Emergency Medical Abstracts. 2 physicians who actually did residency with my wife would banter over journal articles, and they covered between 20 and 30 articles a month. And so I love to exercise. And so whenever I was exercising, I was learning. And I have not found that yet in addiction medicine. So my primary favorite addiction medicine resource is the Addiction Medicine Journal Club podcast.
Oh, you flatter us.
Shameless plug.
Saying that.
Oh, and that's actually part of the reason why I created my own podcast is I wanted to create interesting education in the addiction space. So I'm still looking, but for me, it's usually something audio because I can exercise and I can drive.
Yeah. And can I just point out, you did something, I don't know if you ever put this name to it, we call it pleasure bundling, whereas you like to exercise. And so you bundled your learning with your exercise. And sometimes if there's something you have trouble doing, you bundle it with something that you like to do. And that helps you get it done. So like do it with a friend if you like if you want to hang out with friends, or you said do it while you exercise. So I just wanted to point out you did that strategy unintentionally.
I just feel like I'm fitter and smarter at the end of a workout, and it's cool.
Every time we talk with you, you're off to a fit class of some sort, like a HIIT interval training class. I feel like you're the most fit physician in this audience, at least today.
We did 2 hours of Taekwondo this afternoon. I am beat. So, all right, John, how about you, since you were picking on me?
I find that the same thing. I think it's hard for addiction medicine specifically. I mean, I think for my primary boards, I think it's a little bit easier, right? There's a lot of resources. And I think this is often a topic we talk about, that a lot of the literature for addiction medicine is not sometimes the most user-friendly for some of us. Like a lot of the articles seem more population level. They're kind of more policy related, which are very like interesting reads, but it's hard to translate that to the exam room or the hospital room. So I kind of tend to find that the best one are either articles that are covered like incidentally and other ones that are more like overview type articles. So those are kind of great for like the HIV journals and also Family Medicine Journal. I like ASAM Weekly. So like, just like 10-minute read the highlight stories there. A lot of that is policy and also the same overlap. But I would say that I'm kind of guesstimating here, maybe 10 to 20% of those articles could be applicable to like the exam room, but still not the majority of it. A lot of it's more policy types information. If I'm being honest, I bet you specific to addiction medicine on a weekly basis, I'm probably doing anywhere from 30 minutes to an hour a week just on that topic. And I think it's probably broken up into small blocks of like 10 minutes at a time. So maybe like 10 minutes a day, just down the rabbit hole in some article that comes across my desk. Often those kind of review articles that come up in your email that give me 20 or 30 articles to highlight.
And is that enough, do you think, for you? It's not, sounds like, given everything else you have to know, it sounds like a pretty big chunk of your learning time, actually.
Yeah. I think I think where I'm at right now, it's decent. I mean, there's always new things to learn. I think that, this kind of also reflects, I think, kind of the infancy of this kind of field a little bit, right? I think that there's a lot of learning comes from shared learning. I feel like when we went to ASAM conference, a lot of the best parts of that was people just talking in the room about what they're doing. And a lot of it's not super high level research, right? A lot of it's like anecdotal, like I'm doing this. Really, you're doing that? And like, that's interesting to try that. I might try that. I don't feel like we get these large RCTs that we get for other things. I mean, how many trials have we seen about cholesterol statins for heart disease? I mean, we've studied that. We know it's good.
So many.
Yeah, I'm like, why are we still studying that? And then we can't even answer the basic questions for addiction medicine. And I don't know, maybe a question for Tom. Where do you think we sit? Like, do you feel like we've just entered this space as like health professionals? Because I feel like we've talked a little bit about this offline before that, I feel like recovery community has kind of been somewhat independent of the medical community for a long time.
Yeah, I mean, and certainly treatment has been separated out from the rest of medicine for a very long time, and with some really substantial consequences. So I think it's interesting. I mean, I think it's obviously a huge addition from a quality of life standpoint. But I think the other thing that I was reflecting on that having more physicians really heavily involved is you all have a lot of more accountability than like we have historically had around kind of addiction treatment and recovery, and so that's, I think, a reason that a lot of folks that work in this space don't necessarily haven't historically done a great job of keeping up with what's kind of on the edge and that sort of thing. Obviously, there's a lot of great clinicians out there and a lot of great addiction medicine people, but the accountability hasn't been there. And so, it's not like as clear when somebody's doing something they shouldn't be doing as it is for, when you all are prescribing things. And, it's all documented and has historically been documented. It's a lot more complicated when somebody's using an ineffective counseling technique, or somebody is driving patients away because they're stigmatizing them or just ineffective as counselors. That data should be there, but historically there just hasn't been a lot of accountability. And so, it's just the questions are a little bit more complicated. I think that kind of leads into where, the literature I'm tracking is a little bit different than the literature y'all are tracking, in terms of looking at, okay, what are effective techniques, but also, some of the research that I'm involved with our Collegiate Recovery Research Collaborative is just to prove our worth, right? Just to prove that we belong in the space. In Virginia, the peer profession is 9 years old, right? So you can't possibly have any robust data to say this is definitely working, right? And to try to track that in this rapidly growing space and be able to like say anything definitive about any of that is basically impossible after such a short period of time. So it's very much especially the peer recovery space is very much a build the plane as we're flying it from a research perspective, even though we have a long history of robust peer-based healing from addiction, and we have a fair amount of literature specifically about 12-step and 12-step facilitated, but we don't about this whole kind of peer recovery field, which really pushes beyond that. So I love, in terms of research sources, recoveryanswers.org is done by the Recovery Research Institute.
I love them. Excellent email newsletters.
They are great. John Kelly and their team, they're just Brandon Bergman and Emily. They're just awesome down there, or up there in Boston. And then I listen to y'all's podcast. And then for me, organizing these events, so organizing our research collaborative and then organizing our spring conference is just huge for me to stay up to date, because that kind of other person accountability is important for me, and the kind of community connections as well.
So I was going to say, we're getting pretty close to the end of the time we set aside. So Sonya, I think the last 2 points we were going to go over is how do you make the learning stick once you found your resource and set aside the time to do it? And then how do you make the learning that you do count? How is it useful? How does it help you? Do you want to start?
Yeah. Well, sure. I mean, active learning, one of my other little niches is academic coaching and performance improvement. And it's got to be active. So whatever that means for you, something to make it stick. For me, that's either taking notes or turning it into a project. Like I said before, like I turn it into a lecture or a unit I'm doing for the residents or and sometimes I write lecture slides on topics, even if I don't have a lecture in mind, I just make slides and that's my kind of making it stick. And then someday maybe I'll use them, someday not. And then engaging with other people in person, I think is really important. For me, talking about something with other people is, I feel like is key. So that's the one thing in terms of making it active for me. And then I'm just a huge believer on like, make it count. I say make it count twice or make it count 3 times. So you learn about something and like I said, you turn it into lecture slides or you learn about something and you turn it into a research project. Or for us, we have the podcast. So all of my reading of the addiction medicine literature goes towards I have a goal, which is finding articles for the podcast. And so I actually like read through all these journal table of contents, looking for articles for the podcast. So it kind of, I do something with that knowledge. And I think that's the problem. That's why I need help with my general medical knowledge is I do have my teaching for the residents. So that helps. But it's like, what am I doing with that studying if I'm just like reading a textbook or scanning New England Journal of Medicine articles? I really need to do something with it. So I will turn it into epic, like smart phrases for those of you who use epic, like handouts for patients, anything. I have to do something with the information. And then I feel like I've sort of done 2 things. I'm smarter and I have a product that I can deploy in any other kind of setting.
John, how about you?
I think similar. I think I got to make it come alive somehow. So it's either apply it to a patient, which is probably often one of the reasons that I'm actually doing the research. I got to talk about it with my peers. So we have a doc meeting every Friday with my partners, and often I kind of bring up some interesting stuff just for kind of group sharing, which we have some interesting discussions, or teaching with the residents. So those 3, and the medical students, which is kind of a captive audience. So whoever will listen.
They're forced to nod and show a great interest.
It's the closest thing to a yes man I'll ever get. Like, the I could say anything. The medical students kind of like nod and shake their head. I could be saying some really crazy stuff. And they're like, oh, yeah, that's great, Dr. Keenan. Yeah.
Tom, how about you?
Yeah, I think I like that idea of make it count twice. I hadn't conceptualized it as such, but I always try to work on like one talk a year that's like really a stretch for me. So like last year it was cannabis and I hung out with all these wild cannabis researchers, which is, if you want to dig deep into a funny topic, all the different ways they measure how high a mouse is a really entertaining kind of subtopic of research. But that area of kind of developing a talk for a new area that I don't know a lot about in terms of addiction. And then also just like the conferences, I'm always looking for great speakers. So watch out, Casey, for our conference and, that kind of thing. So that really keeps me fresh. Just, spending some time listening to people I admire is great.
So I have to say, and I'm going to try to be funny again, is I think we just all need to marry the right person. Because for me, being married to another addiction medicine doctor is great. It really helps. But yeah, for me, it's all about teaching. So as I mentioned, when I was a resident, I wanted the hardest topics because I had to understand them to be able to teach them. And so for me, it's like, oh, this would make a great podcast episode. Or I'll have a casual conversation with a colleague and they'll say something like, wait, I need to know more about that. Can I interview you? Same thing with my patients. I've got a couple of patients that I've interviewed on the podcast. And it has always been one of my life goals to find what I don't know and try to learn about it. So I think it's fun. It's my daughter. I can hear her rolling her eyes from the other room. I love trivia. I love learning and facts and knowledge. And it's enjoyable to me to expand my brain. And that's been very motivating for me. But in terms of using it and making it count, I totally agree. Taking notes, turning it into a handout or a smart phrase, or for me, oh gosh, that would make a good podcast episode. And I've actually started now, anytime I lecture, I record myself and use it to make a podcast episode just because it saves time. So
There you
yeah,
go. Making it count twice. Well, this was awesome. I feel like I definitely got some good ideas from you guys. I mean, to me, it seems like all of us, and maybe this is just us, or maybe this is everybody, are kind of project people. Like, to force ourselves to learn, we'll pick something that makes us learn. The sort of sitting quietly by yourself and reading the textbook from cover to cover doesn't seem to work for any of us. But that's fine. That's fine because I think all of us are doing good work, and I know for myself, I'm always striving to find a process that will keep me being the doctor I want to be.
yeah, this has been a great topic and love the collaboration. Truly, Addiction Medicine Journal Club is where I get most of my medical literature.
Oh, now that's like a lot of pressure. Uh-oh.
Well, I give you guys shout outs, like the most recent one I did on methamphetamine addiction. I referenced the podcast episode you guys did on the Vyvanse study. So, yeah. Anyways, love the collaboration.
That was all John. And I'll put in the show notes, I'll put links to these various resources that we mentioned on the podcast and a few more that I like. And that's it. I hope everyone has an awesome night.
Well, you guys are at bedtime. I've got to go make dinner for my family, so.
All right. Good night, everybody.
It's great chatting with you.
Thank you for listening to the Addiction Medicine Journal Club. We would really like to hear what you do to keep your knowledge current. Send us your comments on social media, email, or join our Facebook group. The links are in the show notes. Original theme music was composed and performed by Benjamin Kennedy. Audio editing by Michael Bonanno. Produced by Dr. Patrick Beeman and Ars Longa Media. Thank you again to Dr. Casey Grover from the Addiction Medicine Made Easy podcast and Tom Bannard from VCU. Addiction Medicine Journal Club is intended for educational purposes only and should not be considered medical advice. The views expressed here are our own and do not necessarily reflect those of our employers or the authors of the articles we review. All patient information has been modified to protect their identities. Thank you for being part of the conversation. Have a great day.